Shoulder ultrasound, what a surgeon would like to know.
I have to say from the get-go that I just love ultrasound. I'm on my third machine and I'm very fortunate to have a very experienced sonographer, Lisa Hackett, who works in my clinic every time I'm there. It's an invaluable tool. Ultrasound is most helpful for the rotator cuff. The rotator cuff is such a key, important part of the shoulder, and ultrasound gives a really good image of it, and it tells us whether it's damaged and if it's damaged by how much. That information is crucial. What I want to know is whether the rotator cuff is torn or not, and if it is torn, the nature of the tear. In other words, is it a full thickness tear? Is it a partial thickness tear? And if it's a partial thickness tear, is it on the undersurface or on the bursal side of the rotator cuff? If it's a partial thickness tear, I want to know what percentage of the thickness of the tendon is torn. Because we know that if the tendon has a partial thickness tear and it's more than 50% thickness torn, then it's likely that that tear is going to progress. So if it's more than 50% in the terms of the thickness torn, then I usually recommend surgery. If it's less than 50%, then we can try non-operative treatment for that tear. Now, if it's a full thickness tear, I want to know the size, because we know the outcomes of surgery are very much dependent on size. Small tears, those less than say 1 square centimetre, do extremely well. The chances of re-tear are very low, whereas large tears, let's say 8 square centimetres or bigger, the chances of re-tear are much greater. So we're perhaps less likely to recommend surgery in patients with large tears. I want to know the dimensions from anterior to posterior and from medial to lateral. If you can actually draw the tendon tear, that's also really helpful. Mostly, of course, the tears are in supraspinatus, so it's very helpful again for me to know where in supraspinatus. Usually they arise from the undersurface of supraspinatus just behind the long head of biceps at the insertion. I want to know where the tear is in relation to the long head of biceps. Is it just next to it? Is it a centimetre posterior, 2 centimetres posterior? That's really valuable information. Now, if it's a massive tear involving supraspinatus and infraspinatus and it's very retracted, maybe you can't even see the tendon edge. That's important information because repairs of those massive tears don't do so well, and it might mean that we need extra things to help us repair it. We might need a synthetic patch available, or a biological patch available, or maybe we might do a superior capsular reconstruction. Or perhaps if they've got some arthritis in addition, maybe we won't do any rotator cuff repair. Instead, we'll go for a reverse total shoulder. I think it's helpful for you to understand that you cannot get an isolated infraspinatus rotator cuff tear. I have never seen one. I've seen many reports with it, but I've never seen one in reality. The tears almost always begin with supraspinatus and then progress on back and can involve infraspinatus. Subscapularis is another matter. So in younger patients, particularly from some significant trauma, they can tear subscapularis, and they're definitely worth fixing. Older patients can often get degenerative tears of subscapularis, and to be honest, I'm not so excited about those. But it is important to know whether subscap is torn or not, especially if there's a supraspinatus tear, because the bigger the tear, the more complete the tear, the less likely a good outcome. The other main value of ultrasound in the shoulder, I think, is to help diagnose shoulder stiffness. Obviously, that's pretty much a clinical diagnosis. But we need to rule out arthritis, usually with an x-ray, though ultrasound can point us in the right direction. And we need to rule out a rotator cuff tear. Ultrasound again can do that. So when you abduct the arm, when you're doing ultrasound, and you see blocking, that points towards a frozen shoulder, adhesive capsulitis. Of course, that can often go with a rotator cuff tear, but many times it can be an idiopathic frozen shoulder. And that's really helpful to know. We've got good treatments for frozen shoulder. Arthroscopic capsulitis is a really great treatment. That's where I go inside with the arthroscope and cut the capsule all the way around, and it gives patients excellent relief from their pain and restores range of motion pretty much straight away. Ultrasound can pick up calcific tendonitis, calcific tendonitis, as you probably know, is perhaps the most painful condition in the shoulder. There's lots of small crystalline material, often in supraspinatus, which causes a very profound immune response associated with lots of little blood vessels, lots of little nerves, and it is very, very painful. We find that removing the calcific material gives very good relief, and so I use ultrasound again in theatre to guide us to where the material is.
Here we can see some calcific material in supraspinatus. After an interscalene block and under sterile conditions, we can use ultrasound to put a breast biopsy needle into that calcific material. Very helpful for identifying where it is. Then we preponderate the shoulder and put a scope in the shoulder, and now we can follow that needle into the place where the calcific material is. Here we're using a 4mm shaver to debride the supraspinatus tendon where the calcific material is. You can see it's very fluffy and very easy to remove once you know where it is. Another case with more turgid calcific material.
The long-headed biceps. You can see the biceps very well, and you can give us information about whether it's in its groove, whether there's fluid in the bicipital sheath. Fluid in the bicipital sheath to me means that there's some sort of arthritic process going on in the shoulder. And you can tell me whether it's flipped anteriorly. If it's flipped anteriorly, it usually means there's some sort of damage to subscapularis. Many surgeons think that biceps is very important. I'm not so excited about it. I do think it's a pain generator, but I often leave it alone. I don't often repair it, whereas many surgeons will want to do a biceps tenodesis, cut it and put it back into its groove, or do a biceps release. In any event, it's very helpful for us to know whether the biceps is intact, if it's damaged, and if it's in the right place. Post-surgery, evaluating the rotator cuff is very helpful, especially if the patient gets into problems. It's not uncommon for around the 6-week mark for patients to get increased pain and stiffness following a rotator cuff repair. And they often think that they've retorn it. So our standard protocol is to have them come in, talk to them, but then do an ultrasound and confirm or deny whether the repair is intact. Mostly at this point it's actually intact, and they're just getting a bit of a capsulitis. So I find ultrasound very helpful to reassure them that the repair actually is intact and it's doing well. The body is working hard to mend that repair. And we've now got very good data that shows that the patients who do get a bit of capsulitis, some stiffness at 6 weeks, actually have a much better result in the longer term. They're much more likely to heal their repair and get a better result. So we can tell them after the ultrasound, look, your tendon is healed, it's healing really well, perhaps a bit too well, but that's going to help you out in the longer term. And that's really helpful information to provide. At 6 months, I re-ultrasound all our patients post-rotator cuff repair, and I find that incredibly valuable to tell me how I'm going as a surgeon, because that gives me my re-tear rate. When I first started it, to be honest, my re-tear rate wasn't that great, maybe 40% of tendons had retorn at 6 months. And over the years, we've worked hard, working on our technique, working on our rehab, and we've gradually reduced that re-tear rate down to less than 5%. I think ultrasound is a really helpful way of monitoring the success of surgery. Now, how do you work out whether it has retorn or not? It's not that straightforward. The studies show that ultrasound in the published literature is not so wonderful for telling us whether it's retorn or not. I guess the first thing that you need to understand is how the repair has been done. Usually it's with suture anchors, which are made of metal or plastic, and they are placed in the landing site, and then sutures are passed through the tendon and often go back into those anchors. My particular technique involves an inverted mattress suture configuration. So in other words, the suture goes over the top of the tendon, then through the tendon, and then back over the top of the tendon and back into the anchor. Many surgeons use double rows, 2 rows of anchors. Some use a suture bridge type configuration where there's a crossing over of the sutures. Some use tape, which is a thicker material obviously than regular suture, and all these things can be seen under ultrasound. Now, to tell whether it's torn or not, the first thing to look at is the contour, the shape of the top of the tendon. A nice smooth bird's beak type configuration implies that the repair is intact. The second thing to consider is the suture. Where's the suture sitting in the tendon? Actually, it turns out that when we first put it in, of course the suture is on the top of the tendon, but over time it migrates through the tendon and usually sits somewhere in the middle of the tendon. If the suture is sitting underneath the tendon, then that implies that it's failed, that there's no longer a functional continuity between the tendon and the landing site. The quality of the matrix is important. Healthy tendon has lots of parallel fibers running within the tendon. And elastography is nice and stiff, so pay a lot of attention to the quality of that material. A tendon that's early on in the healing process, those fibers are not as well aligned as they are later on. Echogenicity is important.
Hyperechoic implies scar. Hypoechoic implies a failure or delay in healing.
But if there is a small hypoechoic cleft, that's probably not the end of the world. They can heal,
particularly if they're less than 36 square millimeters.
So some things where ultrasound is not so good is instability. As you know, younger patients are more likely to dislocate their shoulder. And that's really a clinical diagnosis in my view, though MRI can often be quite helpful to show the extensive damage to the labrum, and or if there's a Hill-Sachs lesion, a ding on the back of the humeral head. Ultrasound often can pick up those Hill-Sachs lesions, but it's not so good to look at labral lesions. It's just, the labrum is just a bit too deep really for you to get a good look at it. As we get a bit older, it's probably more common to get some tendinopathy of supraspinatus, the so-called impingement syndrome. Ultrasound, I don't know, it's perhaps not so good at looking at tendinopathy, I think, but you can pick up impingement where the bursa sort of slides and catches underneath the acromion. But it's a bit of an overdiagnosis, impingement. I think it's more likely an overuse tendinopathy with a secondary increase in the subacromial bursa. Our standard treatment for that is a cortisone injection in the subacromial space. Again, can be performed under ultrasound guidance, but to be honest, most of the studies show that ultrasound is not necessary for a subacromial injection. You can do it blind. You can even give the injection in the gluteal region and you have much the same benefit. Frozen shoulder happens in 40 to 60-year-olds. It's more common in women than men. It's more common in the left shoulder than the right, and the ratio is 1.3 to 1. Again, as I've outlined, ultrasound is very helpful to show blocking, to kind of confirm the diagnosis, which is essentially a clinical diagnosis. And the management for that can be a cortisone injection, but to be honest, I don't find that helpful in a frozen shoulder. The more useful management tool is an arthroscopic capsular release. But another area where ultrasound is quite helpful is in AC joint pathology. You can see a disruption of the AC joint, or you can see swelling of the AC joint. If you see swelling of the AC joint, it implies they've got AC joint irritation, which is common in, for instance, patients who do a lot of bench pressing, where they're loading the AC joint together. And a good first-line management strategy for that is to inject the AC joint under ultrasound or X-ray with local anesthetic and corticosteroid. Now, as we get into the older age groups, of course, we're going to see more large rotator cuff tears and with secondary cuff tear arthritis. As you know, the humeral head is held in the socket by the rotator cuff, and when it malfunctions, especially if you've got a large tear, the deltoid pulls the humeral head upwards and it rubs underneath the acromion, wears out any remaining cuff. You often get secondary arthritis at the top of the humeral head, and then over time you get arthritis of the whole shoulder, so-called cuff tear arthropathy. Now, for many years this was called a Milwaukee shoulder because the rheumatologists in Milwaukee described it and they didn't really know what was causing it, but we now know it's because of a cuff deficient shoulder. And The management strategies have changed over the years, and now we have, I think, a very effective way of managing it, which is a reverse total shoulder. So a reverse total shoulder is a new shoulder replacement where you put in plastic and metal, but where it differs is that where the socket is, we put a ball, and where the ball is, we put a socket. And this means that the deltoid can pull the humerus around that ball and help the patient regain overhead strength. So it's very effective at taking away pain and giving back overhead function. So I'm sure you'll see that through your practices. Reverse total shoulders, we know over the last 5 years there's been effectively a 20% increase in the number of reverse total shoulders put in every year, year on year. So before we leave the shoulder, I just want to give you a little bit of insight into what things we've learned to be important in determining whether you're going to get a good outcome from a rotator cuff repair. We've done a number of studies with up to 2,000 to 3,000 patients, and the bottom line from those studies is that the number one most important factor determining whether you have a successful repair at 6 months post-op is the tear dimensions. Larger tears are more likely to fail than smaller tears. The second most important determinant is your stiffness. As I mentioned earlier, if the patient is lucky enough to get some stiffness at 6 weeks, they're much more likely to heal their repair at 6 months than those that have a good range of motion. The third most important factor is age. Older patients, unfortunately, are less likely to heal their rotator cuff than younger patients. Fifth factor, in our practice at least, is surgeon or team experience. The more experience we have, the better our results, without a doubt. The sixth important factor is the hospital. Turns out, at least in my practice, that a private hospital, private day surgery in particular, gets much better results than patients who have their surgery in the public system. Finally, I'd just like to run through, I guess, so that you can visualize a little bit more about the rotator cuff and how the surgery is performed. A 3 or 4 minute video showing what I call the undersurface rotator cuff repair, where we can repair the rotator cuff tendon from beneath the supraspinatus in a minimally invasive fashion. As you know, when you scope the shoulder, you can visualize the rotator cuff from below the cuff or from above. And traditionally, an arthroscopic rotator cuff repairs involve scoping the shoulder, looking around the glenohumeral joint, and then replacing the trocar and cannula in the subacromial space, doing work in the subacromial space, in other words, removing the bursa, doing an acromioplasty, and then addressing the rotator cuff repair from above. With this technique, we do everything from below, and that means you can avoid messing with the subacromial bursa, and you don't need to do an acromioplasty. The first step is to establish a posterior portal, and this is just a standard posterior portal, 1 centimetre medial, 2 centimetres inferior to the posterior lateral margin of the acromion, in that soft spot. Nothing new with this part. The second step is to evaluate the glenohumeral joint as you normally would for arthritis, sprain, other pathology, and to identify the torn cuff. The third step, once the torn cuff is identified, is to establish a lateral portal. For this I use a spinal needle to create a direct lateral portal. It's usually near to the anterior tip of the acromion, about a centimetre or so inferior to it.
We're now going to switch to the left shoulder to show you the next steps, and that is, once you've established that lateral portal, to place a shaver through it underneath the cuff to debride the edges of the cuff and to debride the landing site. I think it's very important to debride this landing site and to roughen up the bone to enhance the healing process. The next step is to pass the suture through the rotator cuff. Here I'm using a ArthroCare Opus system to grab the supraspinatus and then pass the suture through it. I particularly like this system because you can pass sutures effectively in a blinded way, And the suture is an inverted mattress type of configuration that helps push the rotator cuff down on top of the landing site. Here we're passing a second suture. The needles are grabbing the suture, pulling it out from the portal, and then we make anchor holes with this punch. I try to make them fairly lateral. Pass the suture through the anchor. Then the suture gets wound in. We remove the punch and place the anchor in the hole, and then squeeze the trigger, and this deploys the anchor in the bone. Then you can wind the suture down to reoppose the rotator cuff. Just showing that again, here we are making the hole. We've passed the suture through the anchor, now we're placing the anchor in that hole, deploying the anchor and winding it in. And the repair is completed. Now if you don't like the repair, you can go on the bursal side past sutures that way and place anchors both from the bursal side and the undersurface. Now I was lucky enough to have a look at a patient 4 weeks after surgery, and here we're looking at the undersurface. You can see the suture there, and the tendon has already reconstructed itself. Then when we looked from the bursal side, again you can see the tendon it's healing, but it looks nice and healthy.
So to summarise, I believe ultrasound is really absolutely crucial for a good surgical practice. It's most helpful in rotator cuff, and it's very important for you to give us information about the nature of the tear, where it is, what size it is, whether it's a partial thickness or a full thickness. If it's partial thickness, what surface is involved, undersurface, bursal side, in the middle, and the thickness of the tendon involved in that partial thickness rotator cuff tear. It's important to know if other tendons are torn, like subscapularis. It's important to know whether there's any stiffness, some blocking going on in the shoulder. Of course, ultrasound is absolutely crucial in determining whether your surgical repair is successful or not, both in the short term when patients might have additional pain and are worried about it, and in the longer term to reassure them that their repair is intact and they can now go back to full activities. So I hope you've enjoyed this presentation. Please feel free to contact me for any further information. Thank you.